Okay, we'll go to our next session. We have two presentations here before lunch, and we're going to take these presentations before questions are open for. So let me begin with Dr. Roth on the update on vaccine implementation planning. Dr. Roth.
Good afternoon. Today I'll provide an update about vaccine implementation planning since the last ACIP meeting in September. Next slide. To begin, I want to bring us back to the overarching objectives for the COVID-19 vaccination program. These objectives help to frame the work we are engaging in with our jurisdictional partners in order to confirm their readiness to receive and administer vaccine product. First, we want to ensure the safety and effectiveness of COVID vaccines in order to build and maintain confidence in this program. Second, the intent of this program is to reduce morbidity, mortality, and incidence of COVID-19 disease. Through this program, disruption to society and economy will be minimized, and healthcare capacity will be maintained. And finally, we are working in a multi-sectorial fashion to ensure equity in vaccine allocation and distribution. These principles guide our planning efforts and push us towards readiness for the implementation of this program. Next slide. As stated before, distribution will adjust as the volume of vaccine doses increase. We continue to plan across 3 phases of distribution and administration. That first limited dose phase, where we are focusing on critical infrastructure workers like healthcare personnel and first responders, and those who are at high risk for severe COVID disease, including people with underlying medical conditions and older adults, including those living in long-term care facilities. As the number of doses increases, we are planning for broadening access to vaccines for other critical workers and people at risk for disease transmission like those in congregate settings. And finally, in phase 3, we will work to give access to everyone who wants vaccination. Next slide, please. These planning efforts culminated in all 64 jurisdictions returning a COVID vaccination plan to CDC based on the interim playbook for jurisdictional operations that was released in September. We also received plans from 5 federal agencies we are working with to receive direct allocations. All plans were reviewed by at least 3 CDC subject matter experts, and written and verbal feedback was provided by October 26th. We also requested executive summaries of these plans by October 26th, and we are still emphasizing jurisdictions to send those in. We will use this information to provide updates about the plans on the CDC website. Next slide. So, not surprising, jurisdictional plans showed both strengths and a few challenges. Noted strengths in the plans included that most jurisdictions had organized their planning around that phased allocation assumptions, with an emphasis on enumerating populations that were likely to be selected for phase 1 administration. Because of longstanding familiarity with the VFC program and seasonal influenza, plans were particularly strong in systems to train and equip providers around adverse event reporting, including VAERS. States had also focused on second dose reminder systems and provided deep operational detail for reminders via text, email, and automated calls. And in many cases, these systems are already live. We are pushing forward into enhanced technical assistance for the challenges identified in these plans, including communications around vaccine confidence and making sure there are expedited procedures for emergency communications should they be necessary. We are working and testing data systems at the jurisdictional level to ensure end-to-end connections are there to administer and track vaccine, and leaning into provider recruitment and enrollment, which is really the cornerstone of all 3 phases of vaccine rollout. Next slide. So now that plans have been returned and the feedback incorporated, our next steps for vaccine implementation are really to ensure jurisdictional readiness. We are working towards a readiness date of November 15th based on projections of vaccine availability. We want to ensure that before product is rolled out, jurisdictions have everything in place to accept and administer vaccine. We're emphasizing the need for a signed data use agreement for those data systems integration to ensure tracking of vaccine uptake, the identification of pockets of low vaccination, identifying and intervening in coverage disparities, and the allocation of vaccine product. Technical assistance is being provided to help jurisdictions identify and enroll provider sites, particularly sites that can administer product to phase 1 populations. We are asking them to select 1 to 5 facilities for the pre-positioning of small amounts of ultra-cold product if an EUA is granted, to ensure that once ACIP recommendations are released, that product is positioned for rapid administration. We are working to confirm that these facilities are enrolled in the VTRAX program to support ordering and receipt of product. And finally, we're working on federal pharmacy partnerships to support vaccination for long-term care facilities, a possible population that would be selected during that phase 1. And we are continuing to move forward with microplanning using various products and allocations to, again, ensure readiness across all different types of vaccination scenarios. Next slide. As we are leaning forward into that readiness state for phase 1, the next phase will come quickly, and we are already thinking through ways to expand access across the next populations to be selected for vaccination. Next slide. Pharmacies can help increase access to vaccines. Almost 90% of Americans live within a 10-mile radius of a pharmacy, plotted here on the map by both the big chain stores shown in red and independent pharmacies in blue. This provides a massive footprint to get vaccine out to the public, particularly in those rural communities. Next slide. For phase 2, we've developed a federal pharmacy partnership strategy for COVID-19 vaccination program. Once we have an adequate supply of vaccine to support broader efforts, the strategy can help jurisdictions increase access to vaccines for general populations. The United States government is partnering with pharmacies nationwide to increase access. Partners who enroll will receive a direct allocation when supply is sufficient, and vaccine recommendations have broadened beyond those initial critical populations. Pharmacy partners include national chains, regional chains, and networks of pharmacy partners and regional chains. 55% of eligible pharmacies have already signed up for this program, and those lists will be shared with jurisdictional partners shortly. Next slide. I want to emphasize, however, that pharmacies are only part of the solution to move vaccine out to everybody who requests vaccination. We need to leverage all resources and partners that will allow for the successful administration of this vaccination program. These include our public partners, including public health clinics and federally qualified health centers, our federal entities who will receive direct allocations to send out to their populations, jurisdictions standing up both mass and mobile clinics, and then we'll also work with our private partners, not just pharmacies, but home health providers, hospital systems, and primary care doctors' offices to really extend that footprint and ensure that the population is vaccinated. So finally, I'd like to end on our vaccine web content, both current and planned. We have sections on our website for the general public, information for providers, and also for our jurisdictional partners. Our version 2 of the interim playbook for jurisdictional operations will be released today, containing new information on vaccine candidates, summary documents on that pharmacy partnership, both for long-term care programs and that federal pharmacy partnership program. We will include vaccine implementation strategies for critical populations and also information on some of these data systems like Operation Warp Speed's Tiberius platform. This update will provide jurisdictions with the information they need to prepare for readiness in the coming weeks to ensure that they're able to implement their vaccination programs. And going back to our overarching objectives, help minimize disruption to society, to the economy, and that we reduce mortality, morbidity, and the incidence of COVID-19 disease. Thank you very much. And I will turn it over to my colleague, Captain Cohn.
Good morning and thank you. First of all, I want to express my gratitude to the hundreds of people at CDC, the Department of Defense, and HHS who are working around the clock together to ensure we can deliver safe and effective vaccines to the American people. But successfully delivering a vaccine is just getting us off the starting line of what we all know is still a long race ahead of us. And to use the words of our esteemed DoD lead of Operation Warp Speed, General Perna, we need all of you and the organizations you represent to see yourselves in this plan to promote confidence in safe and effective COVID-19 vaccines. Increasing vaccine confidence is not a CDC effort or a US government effort. It needs to be an all-of-community effort to be successful. Next slide. We've all seen the reports showing the considerable decline in COVID-19 vaccine acceptability in the US public. Concerns about side effects, whether or not the vaccine will work, perceptions of risk, and concerns about cost and access contribute to this decline. But those who indicate now that they will not get vaccinated may shift as they understand the vaccine process and data over the coming months. We know attributes that can help increase acceptance, for example, if your healthcare provider says it's safe, if there are no costs to the individual, if it'll help people get back to school or work, and if people can get it easily from a walk-in or drive-through clinic, pharmacy, or at their provider's office. Next slide. Most of the US population lies somewhere along the middle of the vaccine demand continuum. They may be less confident, motivated, or maybe less easily able to get vaccinated. So increasing vaccine demand requires not only increasing confidence, but also reducing barriers to vaccine. Dr. Ruth described aspects of implementation that will reduce these barriers to access by bringing vaccines close to individuals and communities, rather than asking people to come to the vaccine. But here I'll focus on the second component of generating vaccine demand, which is building confidence. Next slide. Individuals across the continuum will have concerns. These concerns are understandable and need to be addressed with empathy and transparency. I have questions I want answered before getting vaccinated, but I'm fortunate to understand the process, and I'm confident my questions will be answered carefully by the multiple groups reviewing the safety and effectiveness of a vaccine before it is authorized and recommended. Concerns among healthcare providers is a risk for overall vaccine confidence. Healthcare providers are the most trusted source for health information, and even during early phases of vaccination, when an individual may receive vaccine in their workplace or public health vaccination clinic, they will look to their own healthcare providers or family members in the healthcare field for support in their decision to get vaccine. And finally, communities will have unique experiences in forming COVID-19 vaccine perceptions, and a community's positive or negative impressions of public health and the pandemic over the last several months will inform their starting place on COVID-19 vaccines. Engagement with community organizations and leaders will expand access to clear and accurate information on COVID-19 vaccines. Next slide. So this is the Vaccinate with Confidence national strategy to reinforce vaccine confidence in COVID-19 vaccines. There are 3 pillars to this strategy, which I will go into in more detail: reinforcing trust, empowering healthcare providers, and engaging communities and individuals. Next slide. The first pillar is to reinforce trust. We have to be forthcoming in what information we know and what we don't know. We cannot overpromise on the availability or the impact of these vaccines. While I hope they are, COVID-19s are unlikely to be a panacea, and we don't have an impermeability spell for this pandemic. Vaccines will be an important part of our efforts to end and recover from this pandemic, but we still have a lot to learn about their potential impact. And there will be misinformation, and much of the spreading of this information will be compelling. Being frank, transparent, and clear, not just to the science and healthcare community, but to everyone, is critical. Next slide. The second pillar of the strategy is to promote vaccine confidence among healthcare personnel in their decision to get vaccinated and to recommend vaccination to their patients. I want to be clear that healthcare personnel means much more than those working in doctors' offices or hospitals. Before my grandmother in her 90s passed away, she would hang on every word and recommendation from her doctor, but it was the home health aide who took her to those appointments who reinforced and reassured my grandmother about those recommendations. Millions of Americans don't have a primary care doctor, but they rely on the consult and advice of their community pharmacist. Families of older adults in long-term care facilities will speak to the staff working in that facility when consenting their loved ones to be vaccinated. These conversations need to start early and often, so ensuring healthcare personnel have the tools they need to have empathetic and tailored conversations is critical. Next slide. The third pillar of this strategy is to engage communities in sustainable, equitable, and inclusive ways to increase collaboration and build trust. A common theme from focus groups around vaccine confidence is, I don't want someone to tell me what to do. I want to be listened to and for information to be discussed with me. We need to empower trusted messengers, local community organizations, and faith-based partners, particularly in communities of color, with the information they need to have open and inclusive discussions about vaccination in their community. This week, I saw a list of languages our immunization awardees requested vaccine content to be translated into, and it blew me away. Next slide. While I am not promising that vaccine information will be translated into all of these languages, these are the various languages that were put forward by our immunization partners. Many of these languages I honestly have not heard of before, and there's 22 languages listed here. This demonstrates how thoughtful and inclusive jurisdictions are being in their planning for vaccine implementation, but also illustrates the scope and diversity of communities we need to engage. Next slide. Vaccinate with Confidence is not an advertising, marketing, or communications campaign. It is a cohesive framework to support health departments, healthcare providers, immunization partners, and community partners and leaders' promotion of COVID-19 vaccines. It's using evidence-based content to amplify messages that enable an individual to make the decision to vaccinate. And it's critical to ensuring safe and effective COVID-19 vaccines can help control and reduce the impact of this pandemic. Next slide. We're seeking feedback from a wide range of partners on the Vaccine with Confidence for COVID-19 vaccines framework. So I ask that our partners stay tuned for a short email, which we'd like for them to share with colleagues to review and to provide input back to us. Next slide. And to reiterate Dr. Ruth's last comment, we invite all of our partners and individuals to continue to visit the CDC website to stay up to date on COVID-19 vaccine information. Thank you.
Thank you, Dr. Ruth and Dr. Cohen, for your presentations. We're now open for questions from the voting members.
Dr. Lee?
Thank you for the outstanding set of presentations. I think that you both captured all of the questions that have been swirling around in my head for the last few months, and just, being able to articulate it so well, I think is incredibly helpful. I also think this just gives us a path forward. Looking forward to figuring out how to continue to engage on this. One of the things that I will say, though, just like this is long overdue in terms of just the focus and the attention that all of us need to think about with regard to being able to communicate effectively around vaccines. And as I'm looking at this, I'm realizing there has been significant, and this is just a broader sort of healthcare system perspective, underinvestment in efforts to be able to capture the essence of what you just described and how to move that forward. So I really appreciate CDC's leadership in driving this forward. This is so critically important for public health and population health. I just hope that, going forward, that the CDC and other immunization partners that are critical to the delivery of vaccines are fully supported in being able to accomplish this, as opposed to having this just be one more task that's added on to this complex immunization delivery system. I think I'm really, articulating a need for essentially funding and investment in this kind of work, because it is so crucial to being able to get vaccines to individuals. So thank you, and I again hope that you receive a lot of support.
Thank you very much. Dr. O'Leary.
Yes, thank you. I agree, those were really good presentations. I recognize that children are probably going to be among the last in line, and we're just starting to get pediatric trials going, but I would like to make a plug for really starting to think about the planning process for delivering vaccines to children. The delivery of vaccines to children looks far different than delivery to adults in terms of who's doing the delivery. Much more of the delivery is done in pharmacies, at workplaces, et cetera, in adults compared to children, where the vast majority are delivered in primary care offices. The Vaccines for Children program seems like a sort of an obvious mechanism to help with that, but recognizing many providers don't participate in the Vaccines for Children program, there are going to need to be a lot of considerations, for example, in rural areas where there may not be VFC providers or rural health centers to be able to deliver those vaccines. So I just want to make a plug to begin the discussions on planning for delivery to children.
Thank you for those observations. Dr. Paling.
Thank you for these excellent presentations. What I wanted to do is build on what Dr. Grace Lee had said. And what I observed is you really captured an asset-based approach for the comprehensive diversity of the United States. And I really applaud you on thinking so broadly. I wanted to ask a question because you highlighted the importance of communication. And as we're developing the plans, what is the role for registry?
Sure. So the role of registries, we didn't present our data infrastructure plans today, but registries are an integral part of that IT infrastructure that will support ensuring providers and individuals know when they need their next dose of vaccine, which product they received before. It'll also help states support their view of which communities have gotten vaccinated, where they need to focus their efforts. So we intend on, from an IT infrastructure, having IISs be sort of the main holder where all of this information comes together for states and providers, and in some cases individuals to be able to visualize the information that they need for the program.
Dr. Szilagyi.
Yes, I thank you for two excellent presentations, and this seems like a really good strategy. I support what was said before. I just want to make a couple of points. I do think there are some commonalities to hesitancy for this vaccine and some unique features, and obviously the rapidity of the development, the short time scale, and the issues of the major concerns about trust are dominating people's concerns about this vaccine. So I think the development of safety review groups in many states, groups of states, many health systems, and groups of physician systems, I think will be really important because there will be multiple levels of safety reviews. And I think for individual patients, it will mean a lot when they get communications about vaccine safety from their state or from their health system review boards. The second point is the importance of healthcare personnel. The limited data that we have about hesitancy for a future COVID vaccine do still suggest that that healthcare personnel are very important in terms of information that they give and trust. And I think we can learn a lot from flu vaccine in that regard. And the third point is making vaccination easy and simple for patients. So using visits that are already going to be available, using reminders and education from physicians' offices. Most of that is going to be at the local level. But to the extent that there can be programs and funding to support these activities, I think it would be really important. So thank you for spending a lot of effort in this area.
Thank you, Dr. Dushin.
Thank you. Can you hear me?
Yes, we can.
Thank you very much. And I really want to express my appreciation for the thoughtful approach CDC is taking to implementation and engaging community. I do want to call out, though, that different communities have different issues around vaccine acceptance. And there is a fundamental distrust of both the healthcare system and the public health system in many communities of color that is due to, I think, what we need to acknowledge as ongoing pervasive systemic racism and the ongoing disparities related to social, economic, educational, and environmental factors that lead to health disparities and impact well-being. And I think we need to be very upfront, acknowledge this, and work with these communities to engender their trust and earn their trust. And whether or not that can be accomplished in the short time frame needed for rapid vaccine implementation or not, it is something that we should do.
Thank you for those comments. Dr. Bell.
Thank you very much, and I just want to add my, excuse me, my thanks for these two presentations, which I think are really get to the heart of where we need to go in order to have a successful vaccination program with maximum public health impact. I wanted to actually, somewhat related to what Dr. Dushin just said, I wanted to go back to, I guess, mostly Dr. Ruth's presentation about the state plans, recognizing the importance of equity, the challenges of reaching disadvantaged populations and communities that we've seen with every other vaccine. And I wondered if she could reflect a little bit about on what the states have proposed as ways to do this vaccination program with an extra emphasis on overcoming these barriers that have existed for a very long time, and what some of the strategies that the CDC experts are proposing are that might help us move forward in this regard.
Thanks very much for that question. This is Janelle. And it was very interesting to read through the communication sections of the 64 different jurisdictions. As you can imagine, each one presented a very creative and unique plan based on their own jurisdictional issues. For the most part, across the jurisdictions, there is a reach out to community stakeholders to begin engaging in these conversations. So that was something that was very apparent that most vaccination planning committees had already started reaching out to those local sort of key informants in each community in order to begin those conversations around hesitancy and trying to move forward with plans to vaccinate in those communities, trying to get at exactly what those communities felt was important in terms of access and distribution points that can be quite unique from community to community. So many plans also, I think, were waiting for CDC to put out some guidance. I think there was messaging in those plans that there needed to be a consistent national framework for vaccine confidence, and many plans did ask that CDC put those materials together. I think Dr. Cohn has really described that package and how we're distributing it out to jurisdictions. And so I'm hoping in the next couple weeks, those materials will be embraced and we'll see further movement in that planning effort. Over.
Thank you very much. Dr. Dries.
Thank you. Representing Shay, our members are already actively planning on how to vaccinate our healthcare workers. And so we really appreciate that increasing healthcare worker confidence is one of the pillars of this program. But we do still, we are hearing a lot of hesitancy even within the healthcare worker workforce. And so, I think we cannot really expect anyone to agree to be vaccinated if we're not willing to be vaccinated ourselves. And so, I think if we can include additional strategies on how to increase that confidence within the healthcare workforce, whether it's leveraging leadership within the healthcare facility to promote vaccine. And also, I think there's so many unknowns about these vaccine candidates, specifically around long-term side effects, and that's what I continue to hear people are concerned about. And we're just not going to have that data at the time that these vaccines are first available. So, and also around, extremely rare side effects that might not be identified in the phase 3 trials. So I think if we can explicitly state, use of workers' compensation for any such vaccine adverse events, which would not be mandatory unless the vaccine itself were mandatory, which I think is unlikely. I think that would go a long way to increasing healthcare worker confidence. Thank you.
Dr. Cohen has some comments to make.
Thanks, everyone. I'll just comment on overall on some of the last several comments. Those are all of the things that you touched on related to reaching socially vulnerable communities, healthcare providers. All of those are really critical. And I didn't speak as much about the content that we will be sharing and asking our partners to use, but I think the main message is that we are producing content that we will be sharing with all of our partners in the very near future, but we really need our partners and our national organization, healthcare provider organizations, as well as community partners to amplify these messages, because it coming just from CDC or HHS is not going to be as effective as it coming from all of you. I also just want to say that the vaccine safety section, which is right after lunch, will connect a lot of what you all are saying in terms of ensuring that we are sharing information about vaccine safety regularly to reinforce this Vaccinate with Confidence strategy. It's not only communicating that these vaccines are safe, but it's being transparent and deliberate and ensuring that we have independent reviews of this data to inform what we communicate about these vaccines. Thanks.
We're going to run long into the lunch break, but there are a significant number of individuals that have comments, and I think it's important to hear these. So if you have your lunch, you might as well begin to munch on it now. Dr. Hunter, my apologies, I accidentally skipped over you. Please go forward.
Can you hear me, Jose?
Yes, we can.
Okay, thanks. So I wanted to follow up on Dr. Lee's points earlier about funding implementation with a more specific and possibly pointed question. So my assessment is that COVID vaccine implementation will ramp up possibly January through March and then become really in high gear in April. Just for assumption's sake, let's say that's true. And that what I'm concerned about is that their care funds have paid for an increase in workforce. I know for sure it's doubled the size of at least the contact tracing at the Milwaukee Health Department, and I assume there have been similar increases in staffing at other state and local health departments. But my understanding is that those funds run out on December 31st of this year. And so my question is, what can we do at the state and local health department level as far as implementing COVID vaccination activities if additional funding is not forthcoming?
All right, Paul, let me put on my Secretary of Health hat and just tell you that it really is going to depend on, the individual state legislatures and to see if you can get some of the funds that are not expended to be rolled over. And that is a big issue, I think, that we're all looking at. The hope that we can get additional funding is always there, but we haven't had any positive take on that at this time. So I think it really goes back to each individual state to answer at this moment. And certainly, I'm not sure where your state is at. We certainly have some funds that have not been expended, and we are trying to get these to be accessible to us as the new year goes forward. Over. Thank you very much. And Dr. Freihofer.
Sandra Freihofer, American Medical Association. Thank you for two fabulous presentations. And I want to thank the ACIP for highlighting the focus on the importance of equity and of outreach to these disadvantaged communities. Have a couple of questions. Dr. Ruth mentioned the VTRAC program as a way to order and receive product. We heard a lot today about the pharmacy's role in getting vaccinations out to the public, which, since some of the initial vaccines likely will have these very ultra cold storage requirements, seems to make sense. But we also heard today about two vaccines whose storage requirements could be accomplished in physicians' offices. And I really don't have a good feel as to what we should be telling our members right now. Should individual physicians' offices sign on to VTRAC? What have y'all thought that through?
Thanks very much for the question. This is Dr. Ruth. I think what we would like you to say to your members right now is to be speaking with your jurisdiction, speaking with the health departments, learning how they can enroll as a provider, get the provider agreement signed, get enrolled into VTRACs, so they can order and receive vaccine for administration. We, again, want to increase our vaccination footprint broadly and absolutely think that your members are an integral part of that.
Dr. Whitley Williams.
Yes, thank you. Pat Whitley Williams, National Medical Association. Again, I thank you for both presentations. And again, acknowledging the diversity of the U.S. population. I champion and certainly emphasize engagement with, of course, private partners, but also public partners. And you did reflect that on one of the slides. And here, really to engage with community-based organizations and physicians of color who are practicing in these communities. These partners have ongoing and direct contact. They also have the trust of persons in the communities. So I would just encourage to continue to do this, and as was said before, I think it was Dr. Lee, that this type of structured outreach really does require support. And I hope we are able to emphasize that and really work together with our CBOs and our physicians of color. Thank you.
Dr. Freihofer? No. All right. Your hand was still up. I was just double checking. Thank you. Dr. Goldman.
Hello, can you hear me okay?
Yes, we can.
Very good. Thank you, sir. So I want to reiterate and reemphasize some of the comments made, certainly by Dr. Lee and others. This global pandemic has really ripped open the deficits in the healthcare delivery system, especially in primary care, which has been unfortunately failing for many years. And while this is not the right forum to debate the validity of scope of practice and other institutions chipping away at what we do as primary care physicians, I am concerned at the lack of support for primary care doctors. And I do appreciate that we are mentioned in the delivery system, but I would emphasize that we need more structured foundation and support on how we can do that and be partners in order to deliver the vaccines. And I am sensitive to the need of a global delivery system in a pandemic, but I would again emphasize that we really have more targeted support for primary care physicians so that we can continue to deliver vaccines, all types of vaccines, especially COVID, moving forward in the future. So I do thank you for acknowledging the need for private practice and private partnership, and hopefully we can get some more details on how we can really keep them funded and a stronger foundation. Thank you. Over.
Thank you. Dr. Weiser.
Thank you. Dr. Weiser from Indian Health Service. I just wanted to express some of the concerns that we are hearing from tribes as we've gone through this very compressed timeline in trying to be ready for a vaccine. In normal times, the Indian Health Service engages in very meaningful consultation with tribes to have a dialogue and get feedback on decisions that may affect tribes. But with this compressed timeline that we've been working on, it's been very challenging because tribes are being asked to make decisions about distribution and allocation and prioritization without having all the information that they feel they need. And this we have heard from many tribal leaders as well as organizations representing consortiums of tribal leaders. We've been working to try and address those concerns, but it still remains that there are issues related to how vaccine will be distributed, how we will be reporting about those vaccines, ordering those vaccines, where the details have not really been fleshed out fully for tribes to be able to make the decisions that they need to make. And that's just something that we keep hearing from many of the tribes who want to be ready, who want to have the vaccine, but who are still challenged by whether they should choose distribution through a state or through IHS, and would prefer to be able to have both doors open, recognizing logistically how difficult that would make it for actual vaccine distribution to occur. So thank you.
Thank you, Dr. Coyle.
Good afternoon, and thank you all so much for these two presentations. I wanted to just say I think it's incredibly difficult for many of us to just comprehend the level of effort and work that's gone into distilling this down to a couple of slides, but there's been so much work done across the board, and I just want to say thank you to CDC and others that are working on this. I did want to just note one area that I think still needs a little bit of attention, and that's related to the data use agreement. I know that was recently put out to all of the states, and I think if there's an opportunity to pull apart the two components of that data use agreement. Right now, the DUA covers both identified data and de-identified data, and recognizing that it's far more difficult to try and sign a DUA for identified data than it is to sign a DUA for just de-identified data. So I think at the core, we want to make sure that data can move as quickly as there's a vaccine available. In order to do that, I think we just need to look a little bit more closely and make sure that there's some flexibility and create a bridge for jurisdictions that are not able to sign a DUA in its form today. Thank you.
Hi, this is Nancy Messonnier, and I just want to say thank you. We heard you and we're working on it. And I think, just maybe a general comment to our community, in normal times, each of these decisions and documents would be poured over with us and our partners, and you would have had the time in advance to point out vulnerabilities like exactly the thing that you're pointing out to us now about the mixing of those two issues. Sometimes, in an effort to move as quickly as possible, we've really had to short circuit that. And we really think when you come back to us and say, hey, you all, went too quickly here, we think that there's an alternate way to do it. We listen, we appreciate the feedback. And in this specific example, we said, okay, yeah, let us take this back and figure out if we can do it differently. So we continue to really value and work on the feedback and apologize if at times the need to move forward quickly has not given us as much time to be thoughtful. But when you point these things out, we really do try to take action. So thank you.
Thank you very much for those comments, Dr. Messonnier. Dr. Lee.
Thank you. I just wanted to reemphasize what was said before by a few of our commenters. So number one, we know that vaccine development is a huge obstacle and we've invested heavily in it. Recommendations are going to be extremely difficult to make, but I'm confident we will get there. but it's implementation where the actual impact is going to happen or not. And so I can't emphasize enough that, I think the ask is that federal funding really is needed. The same level of investment in vaccine development needs to be made for vaccine implementation, which I think means, and I recognize, there definitely the state strategy needs to happen, but I also think there needs to be a national investment in supporting our implementation partners on this. It's not something you can just kind of do in your free time, as all of us have known for the past 6 months. We're all trying to do COVID in our free time. But this requires, for us to be successful as a country, something more coordinated and a significant investment in the system. Thank you.
Thank you. Dr. Stinchfield.
Phil Nash. First, I just want to say thank you, Dr. Romero, Dr. Cohn, everyone. This 3 days of science is just really quite remarkable. And thank you to everyone at the CDC who's just doing a tremendous job. I want to echo Dr. Lee's comments and say that this is an opportunity for us to really change the way that we work in relation to approving vaccines at ACIP and then leaving that implementation of vaccines to the state and local level. And I think this is a real good opportunity for us to change the model permanently going forward. And then I want to also tag on to the comment about primary care. And I think in some of the earlier phases, the first phase of clinicians would be those who work in a hospital. And where I work at children's hospitals and clinics in Minnesota, we have tested over 800, we've tested thousands, tens of thousands. We've had over 800 positives. And those have primarily been positive in the clinic setting, 43% positive in the clinic, 34% in our emergency department, and just 17% positive in the inpatient. And so I do hope that as we go forward, that that outpatient primary care provider who is the trusted vaccine deliverer in most communities, that there is some language that allows local programs to include them in that first phase. Thanks so much.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association. I want to, 2 comments. I want to follow up on that comment about the primary care physicians. And that is something we are concerned about. Many of our primary care physicians don't have access to adequate PPE, and they are in the front lines, and they are the physicians that patients will turn to many times with questions about vaccines. But another question, and many of these vaccines will require 2 doses. My experience with our immunization registries and trying to figure out which vaccines patients have received if they did not receive them in my office has been very frustrating. And we really need to, as Dr. Lee said, invest in some infrastructure to really get an immunization registry that works, that, this could be the start of something good for immunization in general. And is that the part of the Tiberius platform that Dr. Cohn briefly mentioned? I can't remember. I'd heard that name before, but what are we doing with that, with the registry part?
I also just want to add that vaccine cards will be included in the ancillary kits that all of these vaccines come in. Can people hear me, please?
Could somebody from the audience?
Now we can. Now we can, but we missed most of what you said.
Apologies.
I didn't hear anything. accept the last of that vaccine card.
Okay.
Please start over, Amanda.
Sure. Where should I start? Just that we do, so two things. One is that we recognize that state immunization registries for inclusivity of adult immunizations has lagged behind, and we have been working for the last several months to augment that capability, and onboarding of providers and getting that data into the registry will be really critical. But that is a major challenge and focus that Dr. Ruth pointed out. But we do anticipate being able to rely on immunization registries primarily with backup of immunization cards, which will be accompanying all of the ancillary kits. As you all know, ensuring the product that the individual receives the same product for both doses will be really critical. So we're doing we have a very advanced technological solution as well as a very retro paper and pen solution, and we anticipate or we plan on implementing both. I also, while I have I just also want to acknowledge and recognize that we are we need all of you to help us increase vaccine confidence. We fully also recognize how tired and the amount of effort that all of our partners have been putting into controlling this pandemic for the last many years. And we are doing everything we can to support your efforts. And so we will be relying on you, but we will also be working on ways to have you do that as easily as possible. Over.
Thank you. Dr. Rockwell, is your hand up again?
It is up. I'm sorry. I had it up. I put it down. I put it up because I'm really hungry. But anyway, I thought I needed to join in on the primary care bandwidth. I am with the American Academy of Family Physicians, and I think that it is, first of all, great presentations that are very near and dear to my heart and all my scholarly work for the past several years. But I think when it comes to vaccine confidence right now with this vaccine, what I am hearing from my colleagues and physicians from other specialties who I talk with is their confidence is lacking. So I know this has been addressed, but I just want to really stress that the confidence of the physicians who are then recommending that vaccines needs to be really boosted with language that doesn't necessarily go into the level of study presentations, because frankly, most practicing physicians don't have that much vaccine science background, but more asking or answering questions as to how did this get licensed so quickly when other vaccines take 15 years, for instance. And even if it gets down to the nitty gritty of funding and things like that, I think that would help for other physicians to be able to understand. I know I am being asked constantly about this vaccine, whether I trust it. And my response is I trust the CDC, ACIP, and FDA. So when they say it's okay, then I will say it's okay. And I will be the first to say if I didn't have trust. So I think, but I'm already won over. So getting all the primary care physicians first on board, because they will be giving out much of the vaccine initially, and then tailgating on a lot of the comments. Yes, primary care physicians in the offices, I feel, need to be part of that first wave if they aren't included. Because right now what's happening is physicians don't want to see patients and they want to send them all the way to special respiratory clinics in case that person has COVID. So the whole system is unbalanced right now. So that's all, and I'm happy to talk to others offline if they want to, because I feel very passionate about this, that we need to do this right, and then get our patients convinced that this is safe in order to sort of save our country. Over.
Thank you, and get some lunch so we don't lose you at the microphone. I thank you all for your comments. I don't see anyone else with their hand up. So we're going to resume the presentations. I'm going to extend lunch a little bit by about 5 minutes. So Amanda's shaking her head. Just a second. We'll come back at 1:30 Eastern time. Good. So we'll extend this 15 minutes. So at 1:30 Eastern Time, we'll resume. Thank you.